Okay, in this first section on neurological disorders, we're going to look at cerebral vascular disorders. We'll review the brain blood supply, we'll look at the different types of stroke, and then we'll look at things like subarachnoid, intracerebral, subdural, epidural hematomas. So we'll kind of review all of these blood vessel issues in the brain. And then in a future lecture, we'll look at brain tumors, and then we'll look at headaches. Just mention here that it's helpful as we start now jumping into specific disorders to maybe check the kind of references that are out there to get familiar with them. So I've mentioned one of them in class, and that is UpToDate. So UpToDate is available to you for free and through the school, and that's through the library website. But this is a clinical practice guideline where it'd be very helpful when you type in any condition. It gives you kind of a nice summary, the kind of current approaches and so forth, both the diagnosis and treatment. So it's a very helpful kind of review, and it's continually updated and so forth. So that's a helpful database to have access to. Other databases like Merck Manual, not as specific, but definitely for kind of more general ideas, can be very helpful. And then having a neurology text is not crucial at this point, but if you wanted to gather some clinical neurology, 10th edition is one example of that. Netter's Neurology, these are helpful to have on hand as well. But a lot of this information now is online and easily accessible. If you really wanted to start working into neurological cases, which might be beyond your interest, but there is an interesting, by Lang Publishers, something called a series called Case Files, and they go through individual cases, and they have one on neurology, and it's very helpful to read through those to see, okay, let's test my thinking process here, what kind of testing would be done in this case, and then what kinds of treatments would be offered. Again, this is all level 4 type therapies, and this is more aimed at biomedical providers, but that can be helpful if you wanted to gather more information. And then in terms of Chinese medicine, biomedicine integration, I would recommend Claire's, I believe it's Claire Stevenson's book, Acupuncturer's Guide to Conventional Medicine. And then another helpful one is Anne Zaldua's book, Acupuncturer's Guide to Medical Red Flags and Referrals. So I've integrated aspects of that in the notes, but those are helpful references to have as well. Okay, we already examined the blood flow to the brain and the brain sections, but just to quickly review, the adult brain is about 2% of the total body weight, but it consumes about 20% of all oxygen and glucose used in the body. And neurons use glucose exclusively for ATP synthesis. No glucose is stored in the brain, unlike muscle and liver, so the brain has to be constantly supplied with glucose. And any disruption of that will result in dizziness, confusion, even convulsions if that flow of glucose stops. In terms of oxygen and blood supply, disruptions of 1 to 2 minutes usually will impair neural function, but then after 4 minutes we now have permanent injury, permanent damage to neurons. And remember, neurons don't regenerate, they're usually replaced by glial cells, and you can lose function as a result of that. Cerebral vascular disorders arise from any pathology of the blood vessel supplying the brain. So that could be from a thrombus. Remember, a thrombus is the technical medical term for a blood clot, or an embolus, and that's where this clot, which has formed on the inside of a blood vessel, breaks off and embolizes. That piece now is going to travel further downstream where the arterioles may be narrow and then get stuck there, and that's going to block circulation downstream, and that's called an embolization or an embolus. It could be due to increased vascular permeability, so too much leakiness of the blood vessels, or an actual rupture of the vessel. Now would be a hemorrhage. So we'll see with strokes there's different types. There's either what we call ischemic stroke, which is due to a thrombus and an embolus, or hemorrhagic stroke, where we have a rupture, and they both have to be treated differently. Because in one you need to thin the blood, the other one, thinning the blood, would actually probably kill the patient. Clinically, this is going to manifest either as ischemia, so when you have a disruption of the blood supply, ischemia is going to be, again, a disruption of oxygen. The cells don't die, but they're functioning suboptimally, and then infarction is actual cell death, where we get necrosis of those cells. So going to the heart, jumping over there, myocardial ischemia is where the heart muscle cells don't get enough oxygen. They're still functioning. They're not dying, but they're not functioning optimally, and that triggers pain, and so people feel pain in the heart with exertion, and that's angina. That's myocardial ischemia. But in the case of myocardial infarction, the disruption of blood flow actually kills the heart muscle cells. And just like brain cells, heart muscle cells don't regenerate. They're going to be replaced by scar tissue. And so if the patient lives through this, they're going to lose a portion of that heart muscle. It's no longer going to function like it did before. And some people actually suffer multiple, we'll go into this in the cardio section, but multiple MIs and are still functioning, but their heart gradually is declining in function, and they move towards heart failure. But that would be a difference between myocardial ischemia and infarction. Same with the brain infarction, the cells die. Okay, so cerebral vascular accidents are commonly known as strokes. So we call it CVA in medicine, but in the general public we say stroke. And that's a sudden loss in function of a part of the brain due to poor blood flow. And then it's actually the third leading cause of death after myocardial infarctions and cancer. So this is very important to recognize. What are the clinical manifestations of stroke? What do you need to do when you see someone you think might be having a stroke, and so forth. Just to summarize again, the blood comes into the brain via the internal carotids, and that's going to supply the anterior 3/5 of the cerebrum, and the vertebral arteries, which are going to fuse together to form the basilar artery. And remember, the basilar artery supplies a lot of the brainstem. And so, you know, the medulla, the pons, and then the midbrain. And then it's going to join up and meet the internal carotid in the circle of Willis. And so the circle of Willis, from there to the base of the brain, we have the anterior, middle, and posterior cerebral arteries branch off to supply different parts of the brain. And I showed you in the brain section the different perfusion maps of where the different branches supply. So if you look at the side view here, the brain, you see the anterior cerebral arteries kind of supplying the frontal lobe up into the parietal here. And remember that with the medial longitudinal fissure, we have to look inward as well. So the ACA also supplies this area here of the cerebrum. And remember, that includes both your motor and your somatosensory cortex. So motor and somatosensory cortices. And so, and it's going to affect different parts of that motor or sensory homunculus depending on where the disruption of blood flow is. And then we have the middle cerebral artery, and then posterior, and that's going to reach into the parietal lobe, also occipital lobe, and then temporal lobe. And so again, if we have a disruption of blood flow in those specific arterial branches, we're going to have specific neurological lesions. So I've kind of summarized that down here. ACA, this is again supplying the medial aspect of the frontal lobes, and that's going to include the lower extremity regions of the motor and sensory cortices. So blockage of the ACA or hemorrhage in the ACA is going to result in lower extremity problems. And remember, the left side of the brain controls the right side of the body. So a blockage in the left ACA might result in lower extremity problems on the right side of the body. Okay, and then the middle cerebral artery, MCA, this is going to supply the lateral aspects of the hemispheres, and that's going to specifically supply the trunk, face, and upper extremity areas of the motor and sensory cortices. So problems of the MCA, we might see the upper body, either motor or sensory deficits. That also includes in the left hemisphere, if it's blockage or disruption in the middle left hemispheric MCA, problems in the Broca and Wernicke speech areas. And remember, Broca's area is all about the articulation of speech. So people know what they want to say, they understand the speech, but they just can't say it. And that's called the non-fluent aphasia. Aphasia, remember, is a speech disorder. Versus Wernicke, patients can't connect words, they don't understand them. They have all the muscles intact for speaking and all the nerve impulses for that, but they can't actually articulate what they want to say, and that's non-fluent aphasia. So we might see the problems here. This is actually, I'm sorry, that is fluent aphasia, where we basically can speak, but people say word salad. Basically, the words don't make a difference. So problems in the MCA are going to affect the Broca or Wernicke area if it's in the left hemisphere. Remember, the majority of people, Broca and Wernicke, are most most predominant in the left hemisphere. In the right hemisphere, that's more associated with the emotional content of the speech. So strokes on that side, or disruptions of blood flow of the MC on the right side, we might see that people are still saying things correctly, but it's like the emotional content is gone. So there could be a difference there. Okay, and then the posterior cerebral artery, the main thing there is the occipital lobe, and so we're going to see visual changes in the visual field. And then the posterior inferior cerebellar artery, the PICA, this is a branch of the basilar artery. And this is what perfuses the medulla and the posterior inferior cerebellum. And so here we're going to see things like what's called Wallenberg syndrome. You don't need to memorize that, but that's where we get ipsilateral facial and contralateral body pain and temperature sensory loss, nystagmus, ataxia, vocal cord paralysis, and Horner syndrome, which is a problem of the sympathetic nerves going into the eye and the face. And I'll talk about that later, actually. Okay, so these are just to kind of set the tone here for, looking at where the blood flow is going and what specific disruptions might result in. Okay, let's look at cerebral vascular accidents in more detail here. So this is a rapid loss of brain function or functions from a disturbance in the brain blood flow. And that's where the deficits actually in a stroke persist beyond 24 hours. If they're less than 24 hours, we tend to think a patient has what's called a TIA, transient ischemic attack. Not as serious as a stroke, although that might be an indicator of future potential stroke. So CVA, the neurological deficits last for more than 24 hours. And the functions lost relate to specifically the area of the brain that's damaged. This is a medical emergency, so this is a red flag. So it's important to understand what are the signs and symptoms and what to do. This can cause permanent brain damage. It can be fatal. In 2004, it was the second most common cause of death worldwide. It's pretty much the same at this point, I think, in 2019. Men are 25% more likely to suffer strokes than women, but 60% of deaths from strokes occur in women. Historically, this was called apoplexy, which in Greek means struck down with violence. So if you read old books and they talk about a person had apoplexy, that means they had a stroke. There are two basic types of stroke, ischemic and hemorrhagic. Ischemic is where you have an interruption of blood flow to an area of the brain, and that's due usually to thrombosis or an embolism. So remember, thrombosis is we form a blood clot on the inside of a blood vessel wall, and that's usually related to atherosclerosis. So the risk factors for that would be the classic things that create heart disease. So high blood pressure, smoking, obesity, poor diets, all the typical things that we associate with cardiovascular disease. We can also have venous thrombosis, and that's where you get something like a deep vein thrombosis, and what can happen there is it can embolize. Now, we'll talk about deep vein thromboses later. The good thing, I guess you could say, about DVTs is, let's say you form in your legs a blood clot in the vein, a venous thrombosis, and part of that breaks off and it embolizes. It's going to go to the right side of the heart, and then it's going to go from the right side of the heart to the lungs, and the lungs will effectively act because the blood vessels get smaller and smaller and smaller in the lungs as a filter for that embolus, and that will cause a pulmonary embolus, or a PE, and that will cause respiratory issues, shortness of breath, and sense of chest constriction, that sort of thing. So usually a DVT is going to result not in a problem in the brain, but in the lungs. If you have a condition in the heart, such as atrial fibrillation, where the atria fibrillate, and that's where they just start to beat really erratically, really rapidly, abnormally, the blood will start to pool in the atria, and that can happen in both the right and the left side of the heart. If it happens in the left side of the heart, the blood pooling there will pass into the left ventricle, go out the aorta, and that pooling blood will tend to coagulate. It'll tend to form clots, thrombi, and those will kind of move through the heart, and that will move through the aorta. Some of it will go down further into the body, but the other part will go up to the brain, and that can actually cause blood clots to now enter the brain. And so that would be another possibility through atrial fibrillation. We call that thromboembolism because they're not, the thrombi are not stuck to the walls of the heart or anything here. They're forming inside the blood, and then they embolize, they travel further to the brain. Prosthetic heart valves, also patients are at higher risk for this. So we'll see with AFib and prosthetic heart valves and all that sort of thing, patients generally for life are going to need to be on an anticoagulant to prevent that from happening. Otherwise, they're at very high risk for stroke. Okay, can have infectious, so bacterial endocarditis, where the bacteria infect the heart valves, and that can also lead to thromboemboli, and so forth. Lacunar infarcts are another cause of ischemic stroke, and this is basically where you have, this happens in regions supplying by what are called perforating vessels. And this is more typical in things like chronic hypertension, high cholesterol, diabetes, and so forth. Systemic hypoperfusion, this would be shock, and this is going to affect what are called watershed areas of the brain. And these are areas where there aren't major perfusing vessels, they're just several smaller vessels that sort of supply that area. And then hypercoagulable states where a patient is more prone towards coagulation, and there are specific disorders that we know are related to this. So antiphospholipid antibodies, activated protein C, etc., would be examples of hypercoagulable states. Having tumors, cancer in the body makes a person more hypercoagulable because of the sort of inner state that happens as a result of that tumor. Oral contraceptives, OCPs, and smoking, that's a bad combination. Birth control and smoking together makes a person very hypercoagulable. That would increase the risk of stroke. Cranial cervical dissection, this is very rare, but this would be essentially where the vertebral arteries are compromised. You rarely hear this, for example, from chiropractic adjustments. People have had vertebral arteries severed from that. I think the incidence is extremely low. But any sort of trauma, something called fibromuscular dysplasia makes the blood vessels more apt to rupture there, and any inflammatory infectious disease. And then about 30 to 40% of ischemic strokes are what we call cryptogenic. We don't know, they're of unknown origin. So that's ischemic stroke. The opposite would be hemorrhagic stroke, less common. So 80 to 85% of strokes are ischemic. The other 20%, 15% are hemorrhagic, and that is a rupture of a blood vessel inside the brain. This is going to have more loss of consciousness, maybe more severe headache, although it's very difficult from symptoms alone to really differentiate ischemic versus hemorrhagic stroke. And there's two types. There's intraaxial hemorrhage, that's blood inside the brain, and that could be due commonly to things like hypertension, where there's more pressure on those blood vessels, and the basal ganglia is the most affected site, so that's going to affect your motor coordination the most. And then extraaxial will be outside the brain but inside the skull, and that would be things like subdural or epidural hematomas. We'll talk about those. Subarachnoid hemorrhage, and that's usually the result of either head injury, brain trauma, or a congenital aneurysm. So there's an aneurysm there, which is a bulging weakness in the blood vessel. People have it since birth, and then unfortunately at 38 it suddenly ruptures and they get a subarachnoid hemorrhage, which could in many cases be fatal. So these are different types of stroke, ischemic, hemorrhagic. There are a couple of related types of strokes. So silent strokes are silent cerebral infarcts. These are strokes without any outward symptoms, and this is going to increase the risk of future stroke. So lesions are often only visible on imaging. So patients go in for head MRI and they're like, oh, you've had some strokes. It's estimated to occur at about 5 times the rate of symptomatic strokes, and the risk increases with age, and it increases with the classic risk factors for heart disease. So hypertension, high cholesterol, diabetes, again, all of those. May occur in young children and adults, especially with acute anemia, but it can also result over time as you get all these microinfarcts through the brain, long-standing changes in mood and personality and cognition. And that might actually, people would then maybe be diagnosed with dementia. And so we'll see with dementias, looking at the sort of cerebral vascular dementias as an important subtyping of dementias. Not all dementias are like Alzheimer's, which is due to degeneration of the neurons and so forth. Some of them are due to poor vascular function, and it could be from silent strokes. Transient ischemic attacks, these are mini strokes, and these last less than 24 hours. People recover within 24 hours. They recover all lost neurological function. No changes are seen on MRI, so we tend to think that they're not permanent, but they can create the increased risk for actual symptomatic or silent strokes in the future. So TIAs are important to always consider as well. So people have like stroke-like symptoms for maybe an hour or two, and then it just suddenly resolves. So that would be a classic TIA. So what are the risk factors for stroke? Well, the older you get, the higher your risk. So age, that's not controllable. That's just a risk factor though. Hypertension though, this is probably one of the biggest controllable factors. That accounts for about 30 up to 50% of stroke risk, and we can modify this. So this is modifiable risk factor. I mentioned atrial fibrillation. There is a 5% a year risk of stroke with patients in AFib. Now, we'll look at AFib in detail in the cardiovascular block, but there are different types of AFib. Sometimes AFib happens in one episode or two episodes and you never have it again. Others, it's more persistent. So it's the more persistent types that have the higher risk. And again, those patients are usually medicated with some kind of anticoagulant or antiplatelet agent to prevent the thromboembolism. Having a previous history of stroke or transient ischemic attacks. Diabetes increases your risk by 2 to 3%, so along with hypertension, huge controllable risk factor here. And then elevated cholesterol. Statins, which are one of the main drugs used to lower cholesterol levels, we'll talk about those later, lower the risk by up to 15% in some groups of patients. Tobacco smoking, heavy alcohol use, and then diets high in red meat, low in vegetables. We find that things like Mediterranean diet actually reduces the risk by 50% of stroke, and then lack of exercise. So a lot of these are modifiable, and that's why we're always looking at things like hypertension and diabetes and cholesterol in the clinic as really important things that we can address. In Chinese medicine, stroke is known as wind stroke, and the common patterns here would be liver yin deficiency. That usually involves poor glycogen storage and poor ability of the liver to actually put a lot of antioxidants and whatnot into the blood. The liver, in addition to supplying glucose to the brain, really is putting out antioxidants which help to protect the brain and the neurons as well. Phlegm fire, blood stagnation. Blood stagnation would be your classic thrombosis picture, so patients who tend to clot really easily. And again, the risk factors like the high cholesterol, smoking, diabetes all increase the risk for blood stagnation. So we're going to look at blood stagnation and how that can be addressed and compare that to the biomedical notions of thrombosis. Qi and blood deficiency, that would be more anemia in that case, and then kidney, qi, and yang deficiency. We might relate that to the sex steroids, so things like estrogen and testosterone and so forth. We know those actually have a protective role on the brain and on the cardiovascular system at physiologic levels. We hear bad things about testosterone replacement therapy, and that's usually for people taking supraphysiologic levels. That definitely increases your risk of heart disease and stroke. But the physiologic levels that the glands normally secrete have protective roles. Ischemic stroke, we might think specifically in Chinese medicine, this relates to atheroma formation. That would be the plaquing that creates a thrombosis in the arterial walls, and that would be a type of phlegm or phlegm fire. Again, blood stagnation. And then hemorrhagic stroke is going to be more related to heat or yang rising, and then wind and phlegm fire. So those are some comparisons in terms of terminology between East and West there. Our history and PE for stroke. So this is usually the symptoms are going to be sudden onset over seconds to minutes, and the severity is going to depend on the location of the stroke. We can go through all this, but it's pretty obvious if you start to think about how, what are the functions of each region. So if there are CNS pathways like the spinal thalamic, cortical spinal, dorsal column tracts, we're going to see loss of motor function. Again, contralateral to the hemisphere in which the stroke occurs. In the basilar artery, this is going to create a lot of the problems in the midbrain and pons, and that might create the locked-in syndrome. Can create cranial nerve palsies like double vision, drop attacks, difficulty swallowing, difficulty speaking, vertigo, and so forth. These are all brainstem type injuries. We talked about these. These are more bulbar or pons type symptoms. The 4 deadly Ds of posterior circulation stroke, so these would be from the posterior cerebellar artery and so forth, would be diplopia, double vision, dizziness, dysphagia, this would be difficulty swallowing, and dysarthria, difficulty speaking. So those would all be kind of indicating posterior circulation strokes. Basal ganglia strokes would be more motor and potentially sensory strokes. There would be things like what we call clumsy hand syndrome, ataxic hemiparesis, so you walk with an abnormal gait and so forth. So that would be affecting basal ganglia. Problems with the cortex are going to be more associated with higher association areas like vision, hearing, speech, memory, thinking specifically. The problem with things like hemorrhage is that you can have a hemorrhage in a location, but then it can start really compressing surrounding areas of the brain, and so you have sort of a spreading of different loss of different function. Most ischemic strokes are not associated with headache. That's important to consider. A lot of people think headache and stroke go together. If you have a headache, especially with vomiting, that's more suggestive of a hemorrhagic stroke. Usually with the ischemic strokes, there are going to be more focal symptoms. It's going to affect more of a specific area of the brain, versus hemorrhagic is going to affect a broader area and have broader symptoms. And then the stroke manifestations are typically unilateral, contralateral again to the brain region affected. So one way of thinking about this is to use what's called the FAST sort of system here, and that's if 3 or more of these findings are present, the probability of an acute stroke is greater than 85%. So facial weakness, so just look at the patient, have them smile if they can't smile, or if it's asymmetric suddenly, that would be one thing there. Having arm weakness, so have the patient close their eyes, lift both arms straight out for 10 seconds, and if you see the arm drift or so forth, that would be a positive. If they're having difficulty with speech, suddenly they just start slurring their words, and I know many people, that was their first indication. They were sitting at the dinner table and they're talking, and suddenly they start slurring their words, sounding very abnormal. They're still sitting upright, they're having no motor or sensory deficits, but it's their speech that's being affected. So that would be a positive thing there. And then T in the FAST acronym here is time to act. So the point here is with stroke, the faster they get to the emergency services, the more potential brain function can be retained with the appropriate therapy. So need to immediately call 911. So if you have a patient in your office, you see any of these things happening, immediately call 911. And even if it's not a stroke, it's better to be overcautious than undercautious. In the emergency department, there's a more accurate sort of diagnostic system. It's called the Rosier, and this is used by the emergency department staff based on the history and physical exam findings. You can look up what the components are there. So that would be some of the classic signs and symptoms of both ischemic and hemorrhagic stroke. Okay, so let me just say a little bit about the pathophysiology of ischemic and hemorrhagic stroke. So again, what happens with ischemic stroke is you get loss of oxygen supply to the neurons, and neurons depend completely on aerobic metabolism. So they need mitochondria, they need oxygen. They can't use glycolysis alone to sustain their energy. Remember, glycolysis happens in the cytoplasm of cells, and it does not use oxygen. It can be done anaerobically. So anything over a minute to 90 seconds, we're going to start to see brain function affected. And then after 4 minutes, we see actual loss of neurons. After 3 hours in particular of lost brain, lost circulation, we're going to start to see real infarction occurring. So those brain cells are going to start undergoing necrosis. So within 12 to 24 hours after a stroke, we start to see a lot of the blood in that area is now pooling in a way. And then in 24 to 72 hours, we start to see the actual necrosis. Neutrophils start to move in. And then in 3 to 5 days after the stroke, macrophages now come in, and that's usually the microglia, which are one of the, a modified macrophage as part of your neuroglia come in. And then in 1 to 2 weeks, we see what's called reactive gliosis, and that's where the glial cells start to proliferate, and then the blood vessels start to proliferate into that region. And then after 2 weeks, there is a scar left in that region of brain cells that died, the neurons that died, made up of glial cells, and we call that a glial scar. Once the brain becomes hypoxic, you activate what's called the ischemic cascade. So again, the neurons and glia are going to resort to anaerobic metabolism, lactic acid's made, get very low ATP, glutamate becomes excessive. And what happens at this point is that the neuron will actually start to auto-digest. So that's what's going to happen within a day or two here, 24 to 72 hours. We get lots of oxygen-free radicals, and that's going to further damage cells, the extracellular matrix and the local endothelium. And then the breakdown of the extracellular matrix leads to the breakdown of the blood-brain barrier, and then that's going to give you cerebral edema. So these are all some of the events that happen after ischemic stroke. In hemorrhagic stroke, we of course have a ruptured blood vessel. Blood is pooling and it's expanding into the brain parenchyma, but of course the skull is going to keep it from really expanding out, so it's going to just keep pressing and pressing and pressing and compressing brain tissue, and that might block further circulation. And the blood itself actually has lots of free radicals at this point. There's direct toxic damage to the brain tissue. And then there's secondary inflammation that's set up there. So different process than an ischemic stroke, but both result in death of neurons and loss of brain tissue. Okay, so assessment for stroke, again, this is once you suspect someone has a stroke, refer out immediately. But what's going to be done in the ED is they're going to do a rapid assessment using the Rosier, but also what's called the NIH stroke scale. And that's going to gauge the severity of the stroke. So this is an 11-item scale, and you can look at it over here. I'm not going to go through it just now. And then immediate labs will be drawn. So getting a heart, an EKG on the heart. We also call that the ECG. K is cardio in German. C is cardio in English, American. And so the ECG or EKG is going to check for abnormal heart rhythms like AFib. That might be something that needs to be addressed, which is what caused the stroke. Going to check the complete blood count, CBC. That checks your red cells, white cells, and platelets. And that can see if there's any abnormalities there. Check for cardiac enzymes or troponin. That just assesses for heart attack, see if there's any cardiac ischemia. And then looking at the electrolytes and serum glucose, make sure that the patient's not hypoglycemic or hyperglycemic. And then PT-INR PTT, this checks your coagulation time. So make sure a person is not over-coagulated, so they're not hypercoagulable, and that leads to increased risk of thrombosis. Checking for lipids and then oxygen saturation. So these would all be labs that would be drawn there in the ER. And then the first thing that's usually done is an emergent head, not heat, but head CT without contrast. And usually strokes that are less than 6 hours old are not going to be visible on CT, but by the patient's gotten to the ER, they're getting their initial workup, they're going to get the CT scan done. If there's access to an MRI, that can detect changes as early as 20 minutes, but again, most emergency departments do not have access to MRI. MRIs take a lot longer, and so they just don't have that, and they're a lot more expensive as well than a CT scan. ECG and echocardiogram, again, this is going to be checking the heart function. An echocardiogram is an ultrasound of the heart. So it's actually looking for the blood flow going through the heart, looking for any abnormal heart valves, looking for cardiac output, how much blood is coming from the heart. And then different vascular studies might be done, like a carotid ultrasound or a transcranial Doppler, to look at the blood flow in different parts of the brain. But typically the labs would be drawn, and the head CT would be the big thing here. So that would be all part of the assessment of a stroke. So let me say a few words about treatment here. So again, this is a medical emergency. Patients need urgent referral to the emergency department. And even there's no like magic bullet. Basically, a lot of the treatment of strokes is prophylactic. Really, once a stroke has happened, there's nothing that can be done to salvage dead brain tissue, but the goal is to prevent future ischemic attack, so if it's an ischemic stroke. So let's look at the difference between ischemic and hemorrhagic stroke here. So in the ischemic stroke, both of them are usually going to be, patients will be admitted to the ICU from the emergency department. That's the intensive care unit. Patient is stabilized, so the first thing that's done is the ABCs, so airway, breathing, circulation. They're given oxygen, and then IV line is set to give IV fluids and maybe if they need IV medication. Same thing is true for hemorrhagic stroke. But the big difference is in ischemic stroke, if the patient presents to the ED, usually within 3 to 4.5 hours after the initial onset of symptoms. So they're at the dinner table, they suddenly started losing their speech. If they get to the ED and they're worked up within usually the 3 to 4.5 hour window. I give a range there because the old sort of information was that patients had to be treated within 3 hours, but now we know they can go a little bit further, 4.5 hours. They can be given actually what's called TPA. And TPA, or recombinant tissue plasminogen activator. Plasminogen is something found within thrombi that if it's activated will dissolve the clot. So it's a natural substance, it's the body makes it. It's actually integrated into the thrombus, and if you activate it with plasminogen activator, it will actually dissolve the clot. So this is a clot dissolver, basically. And it's if the data suggests that it is given within that 3 to 4.5 hour window, there is unfortunately an increased risk of death, paradoxically short term, but long term the outcomes are much better. Usually it's, I say much better, but it's at least 9% improvement, and there's later mortality. So there's no actual standard of care around this, but a lot of departments will actually administer this. But again, it needs to be given within the short window. If it's given after 4.5 hours, there's no benefit. In fact, the risks will outweigh any benefits. It can actually increase the risk of hemorrhage, and so that's part of the problem. What happens is, what we think happens and why there is a sudden potential increased risk of death right after administering the TPA is that once it breaks the clot down, blood suddenly rushes into that part of the brain that's been hypoxic, and that causes a massive release of free radicals as well as glutamate. And glutamate causes something called excitotoxicity, remember. Excitotoxicity can damage neurons. And so glutamate excitotoxicity is thought to damage the neurons, but that happens within just a short period after that perfusion is restored. But then the long-term outcome is generally better. So kind of a mixed bag there. There's some interest looking at, could you infuse antioxidants with the TPA, and would that actually help? The problem is a lot of those antioxidants can be difficult to get across the blood-brain barrier into the brain and so forth. Anyways, so that is the TPA, recombinant tissue plasminogen activator. Other agents that are given to prevent blood clotting would be just simple aspirin, as well as something called clopidogrel or Plavix, and this is used to inhibit platelets. And that's usually given within the first day of symptom onset, and this is not given with the TPA because that would increase the risk of bleeding and hemorrhage. So that's the first thing, is thrombolytic therapy if it's indicated in that time window. And then blood pressure control would be the next big thing to look at. It's only treated if the systolic pressures are over 220, diastolic over 120. It's helpful if patients are on the TPA because it prevents bleeding. So thrombolytic therapy, blood pressure control might be two aspects that are considered for ischemic stroke patients. And then the big thing is, if they live through this, future prevention. So control their risk factors, hypertension, diabetes, smoking, cholesterol, obesity, maybe daily aspirin, and then, or clopidogrel, and then surgery. And this would be, for example, if they have severe plaquing in their coronary arteries, you can do something, they can actually do something to prevent that from causing stroke. So that's a surgical carotid artery. It's usually non-invasive. They put a catheter in there and they do this procedure. So that's treatment for ischemic stroke. For hemorrhagic stroke, here there's not a whole lot that can be done. Again, the patient's stabilized, ABCs, oxygen, IV fluids. Blood pressure control is something that is a little controversial because increased pressure will make things worse, but decreased blood pressure will also worsen because it'll cause more ischemia. So the blood pressure reduction has to be gradual, and it's usually only indicated if the systolic is over 180, diastolic is over 105. And nitroprusside is an agent that's sometimes given to help with that. The other factor here would be reducing increased intracranial pressure. So all that bleeding is increasing the intracranial pressure, and that can be done with intravenous mannitol, and that basically is going to draw water out of the brain. So that is a hyperosmotic solution. You infuse that into the body, and that's going to suck water basically via osmosis out of the brain. And then diuretics to further rid the body of water. Surgery might be helpful for some hemorrhages. For example, they can go in and actually depressurize parts of the brain by removing parts of the skull, etc. So that might be an option there. And then here too, if the patient survives the hemorrhagic stroke, the risk factors like hypertension need to be addressed. So that's what you can do if they get out of this situation. Now, if the patient lives through the stroke and they have loss of neurological function, the next big thing is rehabilitation therapy. And that's going to usually involve a multidisciplinary team involving a physical therapist, occupational therapist, and maybe even a speech-language pathologist. So those, you could then be part of that member of the team, let's say as an acupuncturist, to actually give them additional support here. The use of acupuncture for post-stroke is still controversial, and that's partly because the data is very mixed and we have to really specify what kind of acupuncture we're using. But there is some evidence pointing towards the fact that scalp acupuncture may have some of the best outcomes with post-stroke recovery. So that if that's something that interests you, that could be a very helpful thing to train in more detail, and then offer that to patients that are going through stroke rehabilitation therapy. Okay, so prognosis is about 75% of stroke survivors are affected by a disability severe enough to decrease their ability to be employed. So not good statistics on post-stroke rehabilitation. Lots of depression, up to 50% of patients become depressed, a lot of emotional changes, and then again cognitive deficits, especially if it affected the cerebrum. Seizures can happen in about 10% of patients, usually in the first week or so following a stroke, and then they typically will disappear, but that's something to be aware of. And again, the risk factors of hypertension, the diabetes, atrial fib, hypercholesterolemia, all need to be addressed and treated. So for our post-stroke patients, again, if this is usually going to need to be something worked up by a primary care or more specialized medical provider, and then you can help support that treatment plan. So they might be on aspirin, that's aminosalicylic acid, clopidogrel, which is the Plavix, or other anticoagulants like warfarin and so forth in atrial fibrillation. We'll talk all about those later. So that would be all part of stroke rehabilitation. Okay, let's look at a few other cerebral vascular disorders that are important to know about. So the first one here is subarachnoid hemorrhage. And this usually results from either trauma to the circle of Willis or what's called a Barry aneurysm. This is a congenital aneurysm. It's a bulging weakness in the blood vessel wall, usually around the circle of Willis. And this might be associated with Marfan syndrome, which is a connective tissue disorder. Things like polycystic kidney disease, Ehlers-Danlos, which is another connective tissue issue, sickle cell anemia, having a history of atherosclerosis, or just a family history of this. And a lot of times it's just idiopathic. People just have a Barry aneurysm. It's unknown where that came from. The classic thing here with subarachnoid hemorrhages is what we call a thunderclap headache. Worst headache, sudden onset, comes out of nowhere, and usually followed by severe neck stiffness. So this is this is typical of the Barry aneurysms in particular. Other signs might be meningeal irritation, so that would include things like photophobia, nausea, vomiting, any of the meningeal stretch signs like the Kernig test and whatnot, where you bend your head up and that stretches the meninges, and that could induce pain. Without intervention, this can result in rapid development of obstructive hydrocephalus. That's where the cerebral spinal fluid can't flow out of the ventricles, and that might also trigger seizures, and that can lead to decreased arousal and even coma and death. So this can be fatal if it's severe enough. About a third of patients will have reported what they call a sentinel bleed. They had days to weeks before the event, they had an abrupt onset headache, they had nausea, vomiting, and transient double vision that then suddenly resolved. So that's kind of a warning sign that maybe a subarachnoid hemorrhage needs to be investigated. The diagnostic procedure here is, again, this is a red flag, immediate referral to the ED. This would be a non-contrast CT to the head, and that has about a 95% sensitivity in severe subarachnoid hemorrhages, but lower in those with the normal mental status. And then secondarily here, an immediate lumbar puncture. And what that's going to be looking at is the presence of red cells or broken down red cells, or yellowish CSF due to the breakdown of red cells, and that can tell you that there's been a bleed there. 4-vessel angiography, and then a neurosurgical consult. Again, this is all going to be done in the ED and ICU. The treatment would be within 30 minutes of onset is just to elevate the patient's head and to help them stimulate hyperventilation, and that's actually going to decrease intracranial pressure. And then in the first 48 hours, it's to really maintain your systolic blood pressure under 150, and that prevents rebleeding. And then after 5 to 7 days, again, you can, to try to prevent vasospasm and further neurological deterioration, drugs such as calcium channel blockers, we'll look at those. They're medication used to lower blood pressure and to also protect the heart. But calcium channel blockers, and then IV fluids, and then pressors, which to maintain the blood pressure. And then treating hydrocephalus, and that might actually be placing a drain in the brain, and then it drains into the thoracic or the abdominal cavity. So it drains out the fluid there. And so that would be a drain for that, or getting serial lumbar punctures just to remove pressure from the intracranial fluid, the cerebral spinal fluid. And then surgical clipping would be the definitive treatment to clip off that little area with the aneurysm. There's another procedure where a coil can be put, like a little stent, inside that blood vessel, and that can be an option as well. So subarachnoid hemorrhage, again, think trauma, berry aneurysm, thunderclap headache, definitely a red flag, emergency referral. Intracerebral hemorrhage would be, we've kind of just talked about that. That would be the kind of causing a stroke, a hemorrhagic stroke. And that would be from hypertension, tumor, anticoagulation therapy, any sort of vascular malformations like the aneurysms. Again, depending on where this might happen, this can have different symptoms, but we kind of went through that, so I'm not going to review it. So the immediate thing to think about, again, is referral, but also a non-contrast CT immediately in the ER, and then elevating the head, maybe doing anti-seizure prophylaxis and so forth. So that's intracerebral. And then subdural hematoma. This one's going to be one to always think about with anyone with a head injury. It typically occurs after the bridging veins in the dura are ruptured. So subdural means it happens under the dural, between the dura and the arachnoid. You can also get an epidural, we'll talk about that, above the dura, but subdural is usually where the bridging veins within the dura are ruptured, and this can happen in the elderly who take a fall, also in alcoholic patients, more likely because of falling. So here is the history of, they have a head trauma, they get headache, and then they're going to have rapidly progressing mental changes, and usually contralateral hemiparesis. So it's going to affect the outer portion, usually the somatosensory and the motor cortex, if it's in that part of the brain, and that can result in contralateral hemiparesis. And then it can be subacute or chronic. So interestingly, some of these can be very slow bleeds, and that would be a chronic. But typically after a head injury, it's going to be more acute. Again, CT is going to show us characteristic signs, so we need to refer out for that. And then potentially surgical evacuation is needed, where they have to actually trepan, remove a portion of the skull, and let that pressure out. Otherwise, it will keep pressing underlying brain tissue, causing more loss of neurological function. Some of them may regress spontaneously, the smaller ones, but this is why after a head injury, after a concussion, we always want to monitor our patients for the next 24, 40 hours, 48 hours in particular, because that's when these things will tend to occur. So if patient goes home, yeah, I hit my head at the soccer game, whatever, I'm fine, and then that evening they might start having symptoms of more confusion, they might start having the motor issues, and so forth, we're going to have to refer to the emergency department right away. So I always tell my patients who come in with a head injury, when they get worked up, they might be fine at that moment, but we have to really be careful over the next day or two. And so they should not be alone, should always have someone monitoring them at that time period. And finally here, talk about epidural hematomas. So these happen on top of the dura, and this is typically results of a skull fracture. So, and that's going to tear an artery, not a vein here, but the medial meningeal artery gets torn. And this happens from severe trauma. There's usually loss of consciousness, and then there's usually a lucid interval after that. You can get what's called uncal herniation. The uncus is really part of the brain that herniates, and herniation, there's different types of herniations, but you can have, for example, this part of the brain, uncus, kind of herniates into the cerebellum. You can even have, in some cases, the cerebellum herniating down through the foramen magnum into the opening where the spinal cord comes in. And that's because of the rapidly increasing intracranial pressure, which is pushing on the brain. So it's literally herniating down through any opening. So that's a real problem of the increased intracranial pressure, is the herniations. With an uncal herniation, you're going to have a coma with what's called a blown pupil. So the pupil will be, patient will be in a coma. They'll have a wide, dilated pupil, and then ipsilateral hemiparesis. So same side of the body hemiparesis. So that's an epidural hematoma. Again, non-contrast CT is going to show us characteristic signs. Sort of a lens-shaped convex hyperdensity, kind of limited at the sutures of the skull. And this needs emergent neurosurgical evacuation. They're going to need to remove that skull and all those skull fragments and then let the pressure drain. And then usually they'll have to put something over that to cover it, obviously. But that will resolve all the immediate increased intracranial pressure symptoms. Okay, so that is it for cerebral vascular accidents. So know the difference between the two different types of strokes, ischemic and hemorrhagic, and then understand subarachnoid hemorrhages, the epi and subdural hematomas, and the consequences from those. So these are things, again, that are all red flag conditions, basically. It's not something you're going to be trying to treat in office, but it's important to kind of recognize and have a general understanding of this, so you know what to look for when patients, for example, come with a head injury or any of the signs and symptoms of stroke. Okay, so that covers it for cerebral vascular accidents.